Hi, everybody. Welcome to another episode of The Heart of the Matter. I'm Anisha, and this is Bourann and Ankit. I thought they were going to
Hello.
introduce themselves,
Sorry.
but I
Hi,
introduced
it's
them.
Bourann.
So today we're going to do something a little bit different than our previous episodes. We've had a brief hiatus, but we're back and ready for business. We're going to talk about the new 2025 hypertension guidelines. The last guidelines were in 2017, so these are the updated guidelines. They were just released in this month, in August of 2025. So I am going to talk about kind of the categories of blood pressure in adults, do a little bit of the basic discussion, and then Bourann and Ankit, they're going to elaborate more. So first, I want to talk about how the blood pressure category of normal is a systolic blood pressure less than 120 and a diastolic blood pressure less than 80. An elevated blood pressure within the elevated blood pressure category is between 120 and 129 systolic blood pressure, and then the diastolic blood pressure is still below 80. Now, stage one hypertension is between 130 to 139 milligrams of mercury. And then that's for systolic, and then diastolic is from 80 to 89. And then stage two is greater than 140 milligrams of mercury. And then for diastolic blood pressure, it's greater than 90. So that's kind of the criteria that we're using to talk about all this overall. So I want to talk about first the recommended blood pressure goals for patients with blood pressure. So, in patients that have confirmed hypertension, who have an increased risk of CVD, cardiovascular disease, a systolic blood pressure goal of at least less than 130, with a encouragement to achieve a systolic blood pressure less than 120 is recommended to reduce the risk of cardiovascular events and total mortality. And this is a class one recommendation. So, in addition, we want to have for adults with confirmed hypertension who are not at increased cardiovascular disease, a systolic blood pressure of less than 130 is ideal, with encouragement again to achieve a blood pressure less than 120 milligrams. But that might be reasonable, but it's not a class one indication, it's a class 2B indication. So again, in patients who again have class or have confirmed hypertension, who have an increased risk for cardiovascular disease, this is the diastolic recommendations. A diastolic target of less than 80 is recommended. And then for patients who have hypertension, again, who aren't at increased risk for cardiovascular disease, the diastolic risk or the diastolic recommendation is below 80, and this is a 2B recommendation. Um, so now I'm just going to talk a little bit about the recommendations for medication adherence. So the strategies that they are discussing. So for a class one recommendation, in adults with hypertension, an antihypertensive used once daily is preferred rather than multiple times daily, which I know is intuitive, but I think it's nice to make everything explicit, and I appreciate that from these guidelines. And then for in adults with hypertension, again, the use of a single pill combination to reduce pill burden is important rather than taking separate pills in order to improve medication adherence. And that's also a class one recommendation. And they also encouraged uses of reminder aids, and that's a class 2A recommendation. So discussions about the choice of monotherapy versus initial combination drug therapy. So in adults with stage 2 hypertension, a systolic blood pressure greater than 140, or a diastolic blood pressure greater than 90. The initiation of antihypertensive drug therapy with two first-line agents of different classes. I think the ideal is in a single pill form, a combination, and this is recommended to improve, again, like I said, the blood pressure control and the actual adherence. And then for patients who have stage one hypertension, um, the initiation of a antihypertensive drug therapy with a single first line antihypertensive drug agent is reasonable, and then to titrate that dose, and then sequentially add another agent as needed or change it. So that's a 2A recommendation. So now, second, sorry. this, so now we just have to, I want to talk about the use of risk-based thresholds for initiation of blood pressure treatment in adults. And then I'm going to talk about the prevent score briefly here, and then he's going to elaborate on it more um, thoroughly. So basically on the blood pressure level only, does the patient have a average blood pressure of greater than 140 over 90 milligrams? If that's yes, you just initiate antihypertensive medications to lower the blood pressure and reduce cardiovascular risk in primary or secondary prevention of the cardiovascular disease. If it's no, though, now we're going to talk about this kind of, like I said, the risk-based threshold. So, does the patient have any existing clinical cardiovascular disease, or congenital heart disease, congestive heart failure, stroke? If yes, then again, you initiate antihypertensives to lower blood pressure, again, below 130 milligrams of mercury. If it's no, though, now we're going to go to the next step, which is do they have diabetes or CKD? Or do they have an elevated CVD score, which is a prevent score rather than the ASCVD score we used to use? If that's yes, then again, we initiate antihypertensives to lower blood pressure and reduce cardiovascular disease. But if that's no, I think this was what's interesting to me is that you can initiate antihypertensive medication, but after we give people 3 to 6 months to make lifestyle changes. So I think that's important. And all of these are class one recommendations. So that's kind of where we stand as of now. Ankit, do you want to talk about the prevent score and how it's different from the ASCVD score?
Yeah, absolutely. So the Prevent Score is a relatively novel risk stratification tool that was recently published in Circulation. Um, I wanted to highlight some of the big differences between the Prevent Score and the ACVD risk calculator. So firstly, the Prevent Score was validated in a much larger patient population. It was validated in 3.3 million people as opposed to the ASCVD risk score, which was 25,000. So you can tell the degree of difference. The other thing, it's incorporating a lot more input into it as well. So for example, you can use BMI, GFR, A1Cs, all these continuous variables that you previously couldn't use, and then the albumin creatinine ratio as well to identify the degree of proteinuria. The other thing that I thought was really interesting is that you can also use a zip code, which is helpful in patients that have a lot of health disparities and health inequities. And then it also eliminates the use of race as well in our new trend to avoid and eliminate race-based medicine too. So the other thing, not only do you have more inputs, you also have more outputs. So it can quantify your overall cardiovascular disease. It gives you separate estimates for different ASCVD events. So for example, CAD, stroke, heart failure. And then it can also generate 10-year risk for patients that are 30 years old, which is new as opposed to patients that are 40 in the ASCVD risk score. Interestingly, I know it's a relatively new score and it requires a lot of prospective data to figure out how it's best applied. But from what I understand, the use of this score is actually leading to the or you're prescribing less statins to people than the ACVD score, which is kind of interesting. So we'll have to see how that applies long term. So with that all in mind, and with all the framework that Anisha kind of presented, I just want to talk about briefly about some of the new updates in the hypertension guidelines too. So firstly, and Bourann will expand a little bit about this. There's a change in terminology from hypertensive urgency to severe hypertension. We see this all the time as we admit patients on the floors and even in the ICU previously. The second thing is aldosteronism testing. So testing for primary hyperaldosteronism is in patients that have resistant hypertension is now a class one recommendation, and this can occur even in the absence of hypokalemia. So we just wanted to point out that hypokalemia is not super common in patients with primary hyper aldosteronism. It's like in the 30% or so. The other thing, which is kind of intuitive, but still need to be standardized. So you don't have to stop your antihypertensive medications when you're undergoing some of this primary hyperaldosteronism workup. The only one you'll need to stop is the MRAs, which makes sense. And that's also a class one recommendation. The other thing which has got an upgrade in the class of its recommendation is the use of ACE and ARBs for proteinuria and CKD. One, to prevent the progression of CKD and then prevent the progression of proteinuria too. But what I thought was interesting is that even if you have proteinuria less than 30 milligrams per gram, you can actually still consider the use of ACE and ARB in patients that are diabetic or have CKD. And then lastly, this one applies more specifically to our CKD patients, but the use of salt substitutes. I've seen this when rotating on nephro, but some CKD patients will use salt substitutes, and a lot of them have a lot of potassium in them. So avoiding that in a CKD patient. But if you're using it and you don't have any baseline kidney disease and you're using it to prevent salt retention and stuff like that, that is now a class 2A recommendation, which is kind of interesting. So I will leave you there and then segue into Bourann talking about how we treat hypertension in pregnancy now.
Yeah. So there are some new recommendations on the management of hypertension in pregnancy. Previously, in the 2017 recommendations, there was, I think, maybe just one recommendation, and it was against the use of ACE inhibitors or ARBs or renin inhibitors in pregnancy. But there has been some expansion, some official guidelines, from these cardiac societies. So the modification to that previous recommendation, which was to avoid ACEs or direct renin inhibitors, has been expanded now. And so, in any individual, this is class 3 recommendation, so we're recommending against, is that any individuals with hypertension who are planning pregnancy or who become pregnant should not be on an ACE, ARB, direct renin inhibitor, nitroprusside, a mineralocorticoid receptor antagonist, or atenolol. And that's to avoid fetal harm. Each one has its own mechanism by which, it can cause fetal harm. Atenolol specifically has more to do with blood flow to the placenta and to the fetus rather than like direct like teratogenic, effects. It's like associated with intrauterine growth restriction, things like that. So that is a modification to a previous recommendation, and then the following ones are all new recommendations from these societies. So this is a class 1 recommendation in any individual with hypertension who is planning pregnancy or who becomes pregnant should be counseled about the benefit of low dose aspirin to reduce the risk of preeclampsia and the sequelae of that. So that is something that is new. That was not previously recommended. Another class 1 recommendation is that any pregnant individual with chronic hypertension, so we're saying pre-pregnancy hypertension, or a systolic 140 to 159, diastolic 90 to 109, again, this is prior to 20 weeks gestation, should be on antihypertensive therapy. And our goal for them is less than 140 over 90. And that is for both maternal and perinatal morbidity and mortality benefit. And then going off of that in a sort of more acute setting, in a pregnant individual who has a systolic greater than 160 or a diastolic greater than 110 that we've confirmed on repeat testing 15 minutes apart should have acute blood pressure lowering therapy administered within 30 to 60 minutes to prevent adverse events. So we are a little bit more strict with our pregnant patients in terms of blood pressure control than we might be with some of the rest of the population. And that, again, is class 1 recommendation. And going off of that, we do have an additional recommendation now. This is in our non-pregnant patients, and also to clarify, our non-stroke patients who have their own set of guidelines about blood pressure management, is how we manage severe hypertension, which is the new term we're using for hypertensive urgency. So this is individuals who have a systolic above 180 or a diastolic above 120. And in these individuals who are hospitalized, if they are there for a non-cardiac condition, and again, these are not pregnant patients or not stroke patients, and we have no evidence of acute target organ damage, that it is not recommended to acutely reduce blood pressure by using either IV or oral antihypertensives outside of their standard antihypertensive regimen. This is something that, we encounter all the time in the hospital. And I think this is an important recommendation to be made. And this is class 3, like I said. So we're recommending against this because there's evidence that shows that there's harm in doing so in this patient population. So these are some of the, new guidelines that have come out, these new recommendations about hypertension across the board in, various conditions, various patient populations, some of our new scoring systems. And then the last thing I was going to briefly talk about, since we are discussing hypertension, and the various ways in which we can manage it is a little bit of information from this trial, which is called the Bax Hypertension trial. It's a phase 3 study, and the results are not fully completed. I'm actually not sure that the study has fully completed, but there are some markers of it that have passed through. So basically, it's investigating this medication called baxdrostat, which is an aldosterone synthase inhibitor. And so the reason that this is really interesting is because we have a lot of evidence in recent times that aldosterone dysregulation is a driver of a lot of the hypertension, resistant hypertension that we see in the hospital or just out in the community. And so by targeting other ways to reduce aldosterone in the body, we may be able to get better control. And so this is a medication that, again, targets aldosterone synthase. And so this study was investigating its both safety and efficacy in reducing systolic blood pressure in patients who have uncontrolled hypertension, which we're defining as patients who are on at least 3 blood pressure medications, including a diuretic. And so there was a sort of like press release by the company that is doing the study a couple of weeks ago, indicating that at these 2 doses that they were studying, which is a 1 milligram and a 2 milligram dose, that they did find statistically significant and clinically meaningful reduction in systolic blood pressure compared to the placebo at 12 weeks of administration of this medication. They also had some secondary endpoints, one of which being reduction in diastolic blood pressure, and some other, markers. And so those were met as well. So this is just kind of, we'll learn more about this study as we get like the final information from it once it's all done. And it is going to be presented this month at ESC. So I'm sure they'll discuss it, at length at that point in time. But this is sort of like an interesting new area of hypertension management, and potentially another medication that we'll be able to use down the line to help our patients who have resistant hypertension. And with that, anything you guys would like to discuss, other thoughts that you have, or things that stood out to you from these new guidelines, these new recommendations?
How much are they paying you?
She didn't even mention the name on
I didn't even, unfortunately, I'm not being paid.
But I think we're just paid in the fact that we're excited about medicine and excited about
Yes,
all the cardiology
they should
changes.
pay me for bringing it up, but no, I'm just kidding.
Maybe in the future. But I think the thing that really sticks out to me is, we all know this, and now we've read these guidelines, and we know that the cardiologists that we work with will have read these guidelines, and hopefully more of the internal medicine doctors that we work with have read these guidelines. But how do we implement that into the culture of hospitals? Because I think we have, different, I think that just the fear around hypotension, hypertension, and managing blood pressure is something that I think we use that, like, it's a vital metric, right? Like, it's a data point that people say, okay, somebody's doing well versus somebody's not doing well. And I think that is the thing that is going to be the biggest challenge in the upcoming years with these new blood pressure guidelines, of figuring out how we, actually make this management outpatient. I mean, this is something that, the 3 of us are going to do, well, outpatient, right? We're going to manage all of our patients outpatient, and we're going to know what kind of regimens they're going to have. But when we're inpatient, that this is not our biggest concern, right? Or that it's not that it's not our concern, but that this is not the primary thing. It actually harms people when we try to manage their blood pressure too aggressively, with increased, actually outcomes from having too tight of blood pressure control. So I think, educating everyone, right, whether that be residents or medical students or attendings or our nurses, or our techs, everybody just understanding that elevated blood pressure is okay if there are no symptoms. That, I think, is going to be no symptoms and no, signs of end organ damage, I think, is going to be it's the biggest takeaway from me, is to see how this actually gets implemented, and how we're going to have to do a lot of education beyond, this podcast, to really implement it and actually see the change.
Yeah, I think this is like a long time coming. I remember reading something similar, like this markedly elevated hypertension or severe hypertension versus hypertension urgency thing. And I think I remember reading that like PRN IV medications for, whatever threshold that you put is actually harmful and at least the worst outcomes in patients. So yeah, this just reinforces those thoughts.
Yeah, for sure. I also think I do think it's nice that we have more guidelines for pregnant women. I think that's really great. And I think it's important for us to have these, I think our OB/GYN colleagues are, they've been putting their patients on aspirin for some time now. And that now I'm glad that we've like fully caught up in our recommendations and just to say, like how important it is and just to have really, really good criteria for everyone to understand all the distinctions because I think that this allows for everybody to navigate it rather than us, rather than OB deferring to cardiology versus a cardiology deferring to OB and everybody just trying to be stuck in the middle. Not that I think there's anything, obviously everybody should be discussing and everybody should be doing their jobs, but I'm glad that it's just very clear. And I think that's really important. I know that's the other thing that really sticks out to me.
Yeah, and then one last thing, because this is something I was just curious about, and it's not even that we even manage it, but like intracranial hemorrhage and blood pressure goals. I remember someone bringing it up a couple years ago, and I was trying to figure out like what the actual blood pressure target is in these patients, and I could not find a good answer. So now we have an answer. I think it's like 130 to 140 for the
Mhm.
first week.
hmm We didn't mention those explicitly, but as part of these guidelines, like you guys are saying, they did address intracranial hemorrhage, acute ischemic strokes, and things like that. So it's nice. It's very clear.
Yeah.
It makes it, sort of black and white in an area that's been not so black and white all the time. And sometimes that gray area, while that does leave room for our like clinical decision-making skills, it can be harmful, in the end if we're not following like stringent guidelines that are based off, a lot of evidence and these like big, strong studies. So, um, I think, yeah, that's pretty much it. I do think this prevent score will be interesting to see how helpful it is or how much it actually ends up panning out in terms of perceived risk versus the actual risk that we see in our patients, as they progress through life. And this underprescribing of statins is also kind of interesting.
Yeah.
It's not what I would expect, to be honest, as we incorporate these other metrics. But, it's possible that some patient populations are at lower risk than we perceive because of, these extra factors that we're not considering. And that some are at higher risk than we perceive because of these extra factors. So it's possible that we're actually able to like tease out better individual risk instead of lumping people into these groups.
I mean, I think what we're going to see is that we're going to prescribe even more medications for hypertension and maybe just a little bit less medications for statins. But I think, we're still going to have the stringent guidelines for, what our LDL levels are and stuff like that. But
Mhm.
it's, I might be biased, but I think it's cool every year how everything's changing in front of us
Mhm.
and how all these studies make it so that we get to implement new things and we get to actually just do right by our patients. That's actually what's most exciting about it. Okay, what's our fun question for the day? Well, we were talking about cheese before we started recording today. So, so I'm gonna ask each of us to talk about what our favorite kind of cheese is or favorite form of cheese. How about that?
What do you mean by form of cheese?
Well, I don't want to bias you, but like it could be like mozzarella sticks or halloumi
Oh,
or
I see.
paneer
Okay.
or string
Uh-huh.
cheese or I mean the joke is that I'm listing a lot of Braun's favorite cheeses.
Yeah. I like
So
cheese a lot,
she's
is
gonna have to
basically
pick
what
a
this is
favorite
about.
cheese.
Yeah. Okay, well, you guys go first. I do need, this is like, this requires a lot of thought on my end. So you guys go first.
Okay, Ankit, you get to go.
I like cheese too, to be honest. I'm trying to think. I like mac and cheese. I don't know if that's a form. I mean, melted cheese, I guess. Queso, I like too.
Yeah.
What else? String
But
cheese.
is it sounds like you like cheddar cheese is what I'm hearing. Because
Oh,
like melted cheese
I'm not
usually has like,
really. When I like, for example, if I go to like Subway or something, or I want like cheese on my burger, I'm asking for pepper jack. Most.
Yes.
okay, sure.
That feels like a classic Indian American choice. We like a little spice, and
I
we all grew up eating the pepper jack at Subway and had the pepper
yeah.
jack on our burgers.
So I don't know if I can choose my favorite form of cheese. I like a lot of cheeses too. So I'll leave you with that.
Okay, a discussion of cheese.
Yeah.
Braun, you get to go next.
Oh God. Man, I just love, I mean, this. I love cheese. Like, I don't think that there's a cheese that is my favorite. It just kind of depends on the mood that I'm in. Um, What would be a good one? I do like Gouda. I would say that's actually, I think, a pretty versatile cheese because
I
it
agree.
can fit well with like the cheddar cheese category, like if you're making mac and cheese, but it's also like a smokier cheese, so you could incorporate it into some other like, palettes. Yeah,
Well,
I,
I mean,
I would
Gouda
say
is good by itself with crackers. It's good on a
true.
sandwich. It's good in mac and cheese. I feel
Yeah.
like you're right. It is very versatile. I echo that sentiment. But I think I would say my favorite form of cheese right now is halloumi. I feel like we've been eating a lot of, whether it's at restaurants or at home. And obviously, Bourann, we all live in Detroit, so we get good access to, good halloumi here. And we get to,
True.
when we go out to eat or even when we eat at home, it's just salty and yummy and it just always hits the spot and I love it. So yeah, but then we can never forget paneer.
Paneer is really good too.
Paneer
I
is
forgot paneer.
paneer is I would say the unanimous uniter of all three of us and that we all love
I
paneer.
love paneer.
That is true.
Yeah. So yeah.
Should we all say what our LDLs are now?
Mine's the best.
Yeah,
That I
probably.
know for sure. But it's
Yeah.
okay. I won't rub it in. Anyways, thanks guys for joining us. It's always our pleasure. Hopefully we have a lot more coming soon. But thank you so much. Bye.
Thanks, guys.
I